Yes, it's
Hear me?
perfect.
Wonderful. Okay, welcome to my afternoon report. We'll just jump on in. This was a case that I had when I was on a telemetry purple, I think at the start of January. So gentleman came in, his chief complaint was dysphagia. And here's a little bit of the HPI. So he was a 60, at the time I think he actually was 66-year-old Spanish-speaking gentleman with a history of HFrEF, paroxysmal AFib. He was non-compliant with his anticoagulation, GERD, hyperlipidemia, and BPH, who came in with worsening shortness of breath, cough, lower extremity edema, and had new onset dysphagia to solids and liquids over the past 2 days. These symptoms have been going on for about 2 weeks prior to presentation. So a little bit more about it. Over the previous 2 days, he developed sudden onset dysphagia to both solids and liquids. He said he was eating rice when all of a sudden he immediately had to vomit and had a globus sensation. And for the 2 days after that, he needed to take small bites of softer food interchanged with sips of water and to, quote, jump up and down in order to get the food to pass and relieve the sensation of the globus. He was noted to be short of breath at rest, was worse with ambulation, and he had intermittent chest pain, but it was unrelated to activity. He'd also been having some chills and cough that was productive for yellow sputum over the past week.
Okay, I think right now, can anyone describe what like a globus sensation is? What do you think of? So Joe, what did the patient describe that made you like describe it as like a globus sensation?
So to me, and what he described was the sensation of sort of retained food in his chest and lower neck area. So really sort of right around where the clavicle bone is a sensation of retained food. I think most of us know what that sort of feels like when you sort of choke on something or take too large of a bite, and you sort of have this retained sensation of mass and pressure in your chest.
Yeah, I think so. Someone commented like a lump in his mouth. Yeah, I think a way to describe the sensation is like not necessarily painful. I think it's right, like some sensation of tightness or something stuck in there. There is such a thing as like a globus sensation like condition, or like we'll get into that later. But for that, you have to rule out other stuff first. Yeah, you can go on, and we'll pause later for questions, I guess.
So here's just a little bit about his past medical history. Surgery's past medical history is as I'd mentioned. I'm going to defer a little bit about his past surgical history for a more interesting case presentation. Social history, he was a former alcoholic. His last drink was over 20 years ago, but he was a pretty heavy alcoholic at the time. And he's a smoker, smoking half pack per day for 30 years. He had apparently quit, but it was in the weeks leading up to hospitalization and the setting of his acute illness. And he was vaccinated against COVID, no booster.
Yeah, I think we can go towards the next slide, and then like we'll pause during the physical exam and return for like questions before the case.
Sure. So these are his list of medications. Important to know that he was not compliant to these meds and was unclear when the last time he'd been taking them. But he was on apixaban 5 milligrams for his paroxysmal AFib, finasteride, and tamsulosin for the BPH. His antihypertensive and cardiovascular meds were losartan 50, metoprolol 25, spironolactone 25, and then he was on pantoprazole 40 milligrams. No known drug allergies. So a little bit more about the patients. He was undomiciled and undocumented. He had been recently staying at a shelter, but in the days leading up to admission, he'd actually been sleeping out of his car. He was recently admitted to the hospital about 3 months prior to the current presentation, and he was discharged with full prescriptions to shelters, but he reports not having taken any medications longer than that. So it was a little unclear when the last time he'd been on his medication. The reason for this was that he can't get refills as an outpatient due to his undocumented status. Since he only has emergency Medicaid services, he can only get care when he's in the hospital. So on review of systems, it was positive for appetite change, weight loss, chills. He was having trouble swallowing, cough and shortness of breath, but no wheezing that he complained of. He was having some chest pain and leg swelling, but the chest pain was non-exertional in nature and sort of unrelated to physical activity. And then gastrointestinal abdominal pain, and was having vomiting in the setting of PO intake. Vital signs and physical exam on admission. His blood pressure was 117/72, pulse 68. He was afebrile. He was the lower end of his oxygen saturation, 92%. His BMI was 18. His physical exam was remarkable for bitemporal wasting, dry mucosa, positive JVD. It wasn't measured in the ED. Respiratory exam was positive for basilar rales, left side greater than the right, but normal work of breathing, speaking in full sentences, no respiratory distress. Cardiovascular exam was regular rate and rhythm, normal S1, S2. There was a holosystolic murmur appreciated. Its location wasn't identified. Abdominal exam was soft. He did have some mild epigastric tenderness, but no guarding, no rebound, and was non-distended. Extremities, he had 2+ pitting edema bilaterally to about the level of the knee, but otherwise normal range of motion, no tenderness. Neuro exam, he was alert and oriented to person, place, and time. Intact cranial nerve exam, he was warm and well perfused.
Perfect. So I think now, before we try to summarize the case, like we can pause for questions, and actually we can go back to the HPI as well. Nadim has a question here. He says, any previous history of dysphagia, any halitosis, regurgitation of food, last TT, size of LA on it?
There was a prior history of dysphagia. No halitosis that was commented on in the charts. He did have a prior TTE. I wasn't aware of the size of the LA at this time, but his EF was 15%. It was in September of 2021. Let me see if I can get up the comment.
Yeah, and Nadim, could you just tell us why you're wondering about these questions as well? Thinking about whether he has a diverticulums. Okay, so I assume you mean like the synchro diverticulum for the halitosis. So that is correct. That commonly presents like that. Galit is asking how much weight did he lose and for how long. So we can start with that, yeah.
Let me tell you exactly how much weight he lost.
And yeah, Nadim and Nobel are saying that left atrial enlargement can cause dysphagia, and definitely someone who has heart failure that is this advanced, and also AFib, which likely tells you about atrial abnormalities and likely like some potentially valvular abnormalities that caused it. It is possible that this could be the case. And sorry, Joe, do you have the number?
Yeah, so his weight was 150 pounds in September, and he was down to 130 in December. So he lost 20 pounds in about 3 months. And on the echo from the prior hospitalization, his LA was described as being severely dilated.
Okay. And okay, so now we don't know that. And then so Errol is asking about changes in his voice, and Kruti is asking if it's dysphagia to both solids and liquids, or was it gradual?
No changes to his voice. At this presentation, it was reported as being a sudden onset dysphagia to both solids and liquids.
Okay. And Kruti, why do you ask that? Does that change your differential, or? Yeah, exactly. So we'll go into it a little bit later, but definitely dysphagia to solids only or solids transitioning to liquids is different than someone abruptly presenting with dysphagia to both. Arpan is asking about palpable lymph nodes, and Nadim is asking about melena and hematemesis.
No palpable lymph nodes appreciated when he presented in December. No melena or hematemesis. And no
Yeah, Arpan also asked about, sorry, Arpan also asked about flushing and physical exam.
No flushing on physical exam. And
Okay.
for the
And again, why do you
regurgitation-
ask that, Arpan? SVC. Okay. And you said no regurgitation, right? You saw Charles' comment, I guess.
Yeah, no regurgitation, but he would describe emesis shortly after eating.
Okay. Any questions about anything else? Physical exam, medications, ROS? Okay, then I guess we can move on.
So the next slide I had was the problem representation. If someone
Yeah,
wants to give that
yeah. Any volunteers, or should I volunteer someone? Nadeem, do you want to give it a go?
Sure. Can we go back to the HPI? So this is a middle-aged gentleman with a past medical history of significant cardiac disease, including heart failure and AFib, who, as well as GERD, I think that's another important past medical history to bring up, presenting with sudden onset dysphagia to both solids and liquids, as well as weight loss. And what else would I say? Can we go back to the physical exam? On physical exam, he doesn't have any signs of lymphadenopathy, but there are signs that he appears to, I wouldn't say cachectic. He has bitemporal wasting, abdominal tenderness more in the epigastric area, and lower extremity swelling bilaterally. Vitals are all within normal limits.
Okay. So did you say middle-aged at the beginning? That's the only thing I caught. Like,
Sorry,
so I think the
elderly.
patient, yeah, like the patient is 67. I think you might be a little bit too nice, considering that middle-aged. But yeah, definitely. I liked how you tried to like summarize it in one word and not fixate on the number. So definitely elderly. I would add another thing is a patient was non-compliant with the anticoagulation. With the AFib as well, that's definitely something important. In terms of the physical, I would try to summarize it like, I think you did a good job trying to point out at some of the pertinent positives. You can say like signs of like edema in bilateral extremities and positive JVD in association to weight loss, which you actually like made a comment on, and I think that's pretty much pretty important. Nadeem, do you want to show us what you have? No, I'm sorry. Joe, do you want to show us what you have?
Sure. I pretty much what you guys had said. I think the only thing that I didn't include in mine, which I think Rafa just mentioned is a good point, is the med non-adherence, or rather, I think a nicer way, the inability to take his meds as prescribed. So I had a middle-aged man, which I originally had on there because, you know, my parents are in their 60s and I was hesitant to want to put elderly, but I think that's a fair assessment. And if you met him, you would not think he was a young 67. An elderly man with a history of HFrEF, AFib, GERD, who presents with acute and chronic onset dysphagia to solids and liquids, and shortness of breath with cough, chills, lower extremity edema, and weight loss, found to have rails, JVP, and lower extremity edema concerning for a heart failure exacerbation. And
Okay.
then
Yeah. Sorry, but yeah, I hadn't realized like you also put like the middle-aged man, but yeah, that can definitely get confusing, especially when we're using only like those words. Like some people might think of a let's say 40-year-old, when you're talking about like a middle-aged man or like 50-year-old, and that can definitely change to your differential when someone is like almost, 70, basically. Like your differential might change in terms of, like malignancy, like you have this patient with weight loss as well. So some things that might change a little bit with that, but I guess
Yeah, I would say elderly is probably more fair, but you try to tell either of my parents they're elderly and they won't take it very kindly.
What I would say about that, what's the limit between middle age or elderly? There's nothing written in stone. Usually, I don't know, most people will use retirement age. So 65, 67 as, the cutoff to say elderly. And I think that's fair because physiologically that's, when changes really start to happen. So, that's my take on that. But again, there's nothing written in stone.
Yeah, thank you, Dr. Pergolini and Joe. I'm on the same boat as you, don't worry, in terms of like not wanting to age my parents, but yeah. Okay, so anyone have any other comments, or we can move over to the next slide if not? Okay, I think we can move on. So now I'm gonna talk a little bit about just how to approach, I guess, dysphagia in general. And I apologize preemptively. I'm gonna try to be brief since I don't know how stable my internet connection is and how long my voice is gonna last right now. But I'm gonna give it a try. So I'm gonna share my screen for a little bit, and I'm gonna try to use a whiteboard. Can everyone see it?
Mm-hmm.
Perfect. So yeah, I guess one important thing, we talked about like globus and these sensations that you have to describe when it comes to the approach of dysphagia. I think one important thing when you're trying to get a history is just like asking open-ended questions, because you can get a lot just from the patient kind of like describing the sensation to you. And I would say some like a thing to keep in mind just in terms of like the patient population that we normally see and like these different sensations that the patients get. It also depends on how like their neurogenic function. So like if you have someone that has had like diabetes for a prolonged period of time, poorly controlled, you might not get the same clinical presentation as a younger middle-aged male or female, but just something to throw out there. And in terms of just like I guess swallowing and the process and how to think a little bit about how to go about it, it's I like to think of just like the process of swallowing in like 3 different phases. So you have oral, and this is a process of just like preparing the bolus, mastication, salivation. So these kind of problems can definitely affect someone with like, let's say, Sjogren's or poor dentition, or just like mostly like some of these problems will present in an older population, though it should not be considered normal for them to have dysphagia just because of that. Then you have the transition phase. This is kind of like also like oropharyngeal phase, meaning like you have the intention to swallow the propulsion of the bolus towards the pharynx. So you have like muscular strength and neurogenic function, some part of it voluntary, some part of it involuntary. And then you have like the esophageal portion, which is all pretty much involuntary. And that kind of like just knowing how it works, then you can start kind of like thinking of how to approach it. Give me 1 second, I'm having some issues here. Anyways, I'll just move around. But basically, in terms of the approach to dysphagia, there are some kind of like buckets that it can be divided in. I don't know if anyone is aware or has any ideas of like how you personally approach dysphagia or how you try to divide it. Give me 1 second. Anyone? So we talked a little bit. So okay, Kruti is saying oropharyngeal versus esophageal. I think that's a very good point, and it's a very good starting point. So I agree. That's kind of how I would go about it. So just putting oropharyngeal. Like, how would you distinguish the 2 of them? Or like, I mean, it's not set in stone, or it's not gonna like completely rule in or out a diagnosis, but just to start having an idea, like what kind of symptoms would oropharyngeal dysphagia present with? Anyone have any ideas? So aspiration, okay, I would say yes, definitely, like difficulty initiating a swallow right away, okay? So definitely with aspiration, you can find, I would say, like cough, definitely. Difficulty initiating a swallow right away. Anything else? Where do you normally feel the discomfort in this type of dysphagia? If you were talking about an anatomic position when you were asking them. In the throat, okay. So I would say like suprasternal, like above the suprasternal notch. And again, that's not 100%. Like in the suprasternal notch, normally it's referred discomfort from the esophagus, but above that, like the higher you go, it's a little bit more reliable that it's might be oropharyngeal. And what else do you have? Any other symptoms? Oh, I see someone else said drooling. Perfect. And you also have nasal regurgitation as well. So these are some things that might kind of like point you towards oropharyngeal versus esophageal. And now, what about esophageal? What would make you think of esophageal dysphagia? Like we said, in terms of location, where would it be located? Like the discomfort or like the difficulty swallowing? Like where would the patients normally point at? Chest, okay. Yeah, and they report also the sensation of food getting stuck. And then if, for example, the patient referred like pain in the chest, and I would say like in a patient like this one, you do have to be careful a little bit with the presentation as well, right? Because he has cardiac comorbidities, you have chest pain, you have I think in the physical exam or like the ROS, it was described some epigastric pain as well. So in older populations, you might have like also like atypical presentations of MI. So that's something as well to consider. But if he referred pain and he were immunosuppressed, what would you think of? How would your differential change? Basically, when you have the pain or the adenophagia, like just with swallowing and excellent. So yeah, you start thinking about some infections in this immunosuppressed population. So when that, you can think of Candida, HSV, CMV, though our patient likely does not have any evident reasons to have like immunosuppression. And so that's kind of the basic gist of it, like how I normally start. And then in terms of the differential, how would you like divide it? So we divide it into big buckets at the beginning: oropharyngeal versus dysphagia, versus esophageal, sorry. And then after that, are there any other buckets that you could just start like splitting them into as well? So acute versus chronic, Sonal is saying. So the chronicity is definitely something that is important. So if you have a patient that presents with dysphagia like immediately, and you have drooling or like, you know, above the neck and everything, like then you might think of, you know, food impaction and you might think of that. Or, you know, like it's different when you have like, you know, weight loss and a progression from solid to liquids and it's something chronic, that will change your differential. But I haven't, like, at least in a diagnostic framework, I haven't seen it like split into two buckets, but that is definitely a great question and something that you do need to take into account while making your differential. So Kruti saying progressive versus intermittent. Yes, solids followed by liquids. So those are very important. And so Kruti, what would you think if it's solids followed by liquids versus solids and liquids together? How would that change your differential?
Okay, so I'm just going to talk. I feel like if I'm thinking solids and followed by liquids, 67, if he has any weight loss, I'm thinking carcinoma or not. If I'm thinking both solids and liquids together, I know he doesn't like age criteria, but I'm thinking Cachexia. If it's like DES, like diffuse esophageal spasm, he also has intermittent chest pain. I don't know if it was with the solids and liquids. So my differential basically would change based on that.
Yeah,
Or like esophageal valves.
Yeah, and I think even though it's not labeled per se, that question does kind of like split it into like two kind of like different buckets, like I was saying. So you're talking about structural, and you're talking about motility. So yeah, as you mentioned, and actually Cachexia can present progressively as well. Like you said, and esophageal spasms is mostly intermittent, and then you have rings, which is structural, but also like they can present intermittently depending on food, versus progressive, like we said, like you might think of like progression of malignancy, but you also have progression of like, other like neurological diseases. So if we went with just motility, what are some things that would predispose, or what are some conditions that cause oropharyngeal dysphagia related to motility? And this patient has a huge risk factor actually for one of them. Cachexia. So I mean, Cachexia I would consider more in the esophageal side of it, because it's in the esophageal sphincter. I'm talking about oropharyngeal right now. Okay, so neuromuscular diseases, yes. Diseases, but I would say in this patient, I would be worried about exactly, Nadim. So this patient we know has AFib and has not been taking his anticoagulation, right? So even though it would not be like, I mean, this patient does not necessarily have the presentation, I think, of an acute stroke. That's something that definitely like should come into mind as well, or at least this patient is at significant risk of, and also Parkinson's as well. Yes, Kruti, very good. And then when talking about like the structural, I think someone asked about halitosis earlier, right? So this is oropharyngeal and structural. So we had mentioned already like Senker. Anything else? Well, here, like we can gloss over it, but it's you can also have malignancies of the head and neck, and cervical osteophytes as well. Like it's another possibility. Now, in terms of you can apply this same logic just to the esophageal dysphagia, but basically, structural versus motility. And any ideas of like what this patient would be at risk for? I mean, we've mentioned like mentioned it several times as well with the weight loss, one big one that we need to think of. Malignancy. So very good. And what risk factors does our patient have for that? Why are you so worried about that? Okay, so GERD, smoker, age, weight loss. I believe he also has alcohol use, right? So just a few things to consider. Exactly, so Cheryl said alcohol use disorder. Yeah, alcohol isn't necessarily related to adenocarcinoma, but it does predispose you to squamous cell carcinoma. So definitely one of the big ones. And structural, you also have extrinsic versus intrinsic. I know someone mentioned left atrial enlargement as well. I mean, this patient has left atrial enlargement, but I mean, I don't know if you would necessarily like fit with the picture of it. And then I also talked about it a little bit. So esophageal rings, and you also have like eosinophilic esophagitis as well. And I mean, we're reaching the end. Like I said, I try to be a little bit brief, but motility, you also have, like we mentioned, Cachexia. So I would describe that as esophageal motility. That can be a little bit more just chronically progressive, as opposed to just esophageal spasms. And Kruti is mentioning scleroderma. Definitely, you can be predisposed to just like fibrosis of the esophagus, but also just if you have like several, let's say, like rheumatological conditions that cause you weakness as well. That's another big one that I think we didn't mention, but just like weakness in terms of the swallowing that also can like predispose you potentially to dysphagia. And I think just to like summarize, I always like to mention that you know, we need to try to link all of this to our patient, right? So out of the presentation, like what would you say like worries you from the patient, like as of now, or like what from the past medical history from the patient would tell you or point you towards one diagnosis versus the other? And we talked a little bit about the malignancy, you know, like this patient has the risk factor: smoking, age, weight loss, alcohol use. Then we mentioned, you know, for CVA, like this patient has AFib without an anticoagulation. What else? I mean, this patient has like also presented with a cough. I think we have not mentioned that. So like, I mean, in a patient that presents with dysphagia and cough, I would also think like, you know, is this oropharyngeal? Like, does this patient potentially have a pneumonia? I know we have another reason for it right now, like this potential CHF exacerbation, but I would not rule out that this patient has potentially like a pneumonia from that as well. And definitely like, you know, the patient has reflux as well, or GERD diagnosed, so to speak. Anything else that comes to mind to any of you that you would like to bring up about this patient history and presentation? So spasm given acute dysphagia to both solids and liquids. Yeah, I think that we might need to tell. So that's the issue about the description of dysphagia. It's very difficult to describe, and sometimes depending on how good of a historian your patient is, it might be difficult to tease out the diagnosis. But if you had acute dysphagia to both solids and liquids that was a little bit like intermittent, then I would think about spasms. With here, like what worries me is like this patient is retaining fluid in the legs, but like and like his body, but despite that he's still losing weight. That's something that like caught my eye as well. So I like before, of course, like, you know, it's you still have to tease out every possibility. But I would very much want to rule out any sort of malignancy as well, just from that. But yeah, that's kind of, I just wanted to go over like the differential framework, and yes, just asking, you know, like the associated symptoms, the dysphagia versus solids only versus solids and liquids, and just the progression of the disease. I think all of those things are important to tease out. And yeah, so that was my spiel. So Joe, you can go ahead and share your screen again. Yeah, and I think a good thing to question is, knowing all of this, what kind of labs, tests, everything would you ask for?
Rafael, before we go there, let me just comment. You know, you did a great, you know, discussion. You know, based on your discussion too, you mentioned the dysphagia due to Candida, herpes, and CMV. So, you know, we don't know in this patient, right, the full history, whether he has been checked or not for immunodeficiencies, right? So that's something to bear in mind. And I just pointed out that he lost weight in spite of being fluid overloaded. So his weight loss is way more significant than the 20 pounds, I think it was, or 30 pounds that Joe mentioned. You know, maybe in another patient, you know, presenting symptoms with dysphagia, the other group of diseases to consider, you mentioned this motility disorder, and you have to consider some vasculitis that can also present with this. So, you know, scleroderma can do it, but I mean, many of them can actually present with symptoms similar to that. You know, I don't think it's the case with this patient. In this patient, I think there are many other things to consider. And then the other thing to mention is, even though I fully agree that cancer is high on the list, you know, patients with advanced CHF may present with, you know, cardiac cachexia, right? And these are patients who present with this, with temporal, you know, muscle wasting, and, you know, they look like they have cancer. And what they actually have is severe untreated heart failure.
Thank you, Dr. Pergolini. I agree. And we actually just had a recent M&M about an immunodeficient patient that was not checked. So definitely a good reminder. Keep it on the back of your mind, see the patient as a whole, like do a thorough history. And that's why I wanted to stress the fact that you always have to try to, tie all of this to your patient and try to keep a broad mind when it comes to differential and just working things thoroughly. So with that in mind, anyone wants to comment like what kind of tests would you do now? Like what would you like to order and why? Or would you just discharge the patient home? Come on. There you go. TT, Nadim. Okay. Okay, now I'm getting flooded. So Nadim is saying TT question mark, CT chest. Okay, TT, I think you had already explained yourself, like, you're worried about the left atrial enlargement. This patient has FRF, apparently with progressive, fluid retention. I think that's great. CT chest, why? Is that also because of you're worried about the compression or anything else you're thinking about? And Cheryl is saying barium swallow. I mean, many times that's what we turn to first in terms of dysphagia workup. Chest X-ray, CT scan. I think chest X-ray would probably be a good place to start, just to see if you have the, bilateral or just pulmonary congestion from CHF versus an aspiration pneumonia. I think we do need to image the lungs just to tease that out a little bit. Sonal is saying endoscopy. I mean, some depending on prior risk factors, I think some GI attendings might go for endoscopy even before the barium swallow, though that's I mean that's a little bit depends, like I said, on the history, if they have any prior caustic ingestion surgeries or any risk factors to find something there. Many times they just decide to play it safe and do the barium swallow before that. Unless there's a good reason why they should do the endoscopy first. Nadim is saying to look for malignancy. You mean an external compression to the esophagus? You mean mediastinal mass or something like that? Is that what you mean, Nadim? Okay, I mean that would be possible, but I think we need to tease that out a little bit first, and the barium swallow would definitely points towards something if necessary as well. Anyone, like I mentioned, so this patient has epigastric pain and has a history of CHF and I believe hyperlipidemia. Elderly gentleman. No one is worried about, let's say, MI or anyone would think pro PKG. I don't know. I guess definitely wouldn't necessarily cause the dysphagia, but I guess it could definitely be something that you would want to rule out because it could be a another misdiagnosis with unusual presentation. Any lab work? I think we only got mostly imaging requests. Okay, so sometimes if you have anemia as well, for example, in the CBC, that could point you towards a different diagnosis, chronic disease. So Kurti is saying CBC, BNP, VNP. Okay, BNP obviously for CHF. Now we're saying HIV. Okay, I think that's a good thought, and definitely before just doing it as well. I would also ask about risk factors, maybe get a little bit of a better social history as well. But definitely good thoughts. Okay, so I think we can now move on to the workup, Joe.
So this was his initial set of labs. I think they're most interesting for being largely unremarkable. Mild 13.5, a little bit of elevated coags, nothing crazy, a little bit of a high AST. I think most significantly, whereas BNP and troponin were up 3,000. His baseline was around 1,000, and his troponin was peaked at 0.041. I think some other things you guys wanted were a chest X-ray. They did do that on admission. This was the admission chest X-ray. Does anybody want to say what they see?
Nadeem is saying cardiomegaly. And so is Cheryl. And I guess it definitely seems like, you know, megalous heart. But I think is this a portable or a PA? It seems like a portable, right? Or no?
This was
I'm not
actually
sure.
a PA.
Oh, okay, so perfect. Yeah, just remember to double check that every time when you mention cardiomegaly, because it can be a little bit tricky, and especially sometimes like whether in the ED or floors with patient moving, many times providers will just get the portable. So just always double check that. And so Kruti is saying bilateral pleural effusions, vascular congestion. Sonal is saying bilateral ground glass infiltrates. Galit is saying blunting of the angles. So I think I definitely see like the blunting of the costophrenic like angle on the right side as well. A little bit harder to see on the left side, but I think that's also telling. And pacemaker. Yeah, I mean, seems like it, right? There's a, you can see it, I guess you can't see my mouse when I'm pointing, but, or something. Okay, fair enough. So Joe, what was described in the chest X-ray, or how do you interpret it?
So I interpreted as, I read it as cardiomegaly, given that it was a PA and he was standing. I also thought there was some pulmonary edema where it looks like there's increased vascular markings when you go up into the superior lung field. And then I read them as bilateral pleural effusion, since, as I think someone mentioned, there was blunting of the costovertebral angles. There's not that nice sharp line that you see there. And I didn't appreciate it, but someone on the radiologist did read left perihilar and right lower lobe ground glass airspace disease, which they thought represented edema or superimposed pneumonia. And he did have a pacemaker, and that was, turns out one further chart review had been implanted for his low EF. So it did look like from the chest X-ray that he was in some sort of heart failure exacerbation. So the next thing that people wanted to do is they wanted to get an echo, which they did do. This is the echo report. So I think I had said severely dilated. It was moderately dilated in the previous echo about 6 months prior to this. So now his left atrium is read as severely dilated. Left ventricle severely dilated and diffusely hypokinetic. His EF was read as 10%, so it had dropped 5% from his prior echo. As I mentioned, severely dilated LA, severely dilated RA, severe mitral regurgitation, severe tricuspid regurgitation, severe pulmonary hypertension with a PA systolic pressure of 80, very high. And compared to the echo in March, the right ventricle was noted to be significantly worse regurgitation and pulmonary hypertension. The left ventricle function was read as being low. So put together with the chest X-ray and the labs and his presentation with the elevated BMP, the vascular congestion, it seemed like he was in a heart failure exacerbation. And cardiology was brought in to evaluate him. Oh, sorry, cardiology was brought in to evaluate him. They didn't think the troponin was an ACS. They thought it was secondary to his heart failure. And they started medical management for the exacerbation. And then GI was consulted for the dysphagia. And I'm going to cheat the history a little bit. One thing that they did do for the initial workup of this dysphagia was get Barium Swallow, like you guys had mentioned. I tried to import the videos. We'll see if it works. Videos didn't work, but you can sort of see in this one how tortuous and in various areas where his esophagus is severely dilated. This area, can you see my mouse? Yeah, this part where my mouse is pointing is the most stenotic part of his esophagus. And you can actually see when the video is played that it does look like he passes material, but it happens very, very slowly. And the bolus will get stuck around here. And then you'll see sort of in the preceding 10 seconds of the clip, sort of dribbles down through the stenosis into his stomach. Now, this is a little slide for discussion. Does anybody have any questions or what they want to do next for this guy before I tell you his whole hospital course?
Could you just describe the findings again of the esophagram?
Yeah, sure. Let me see if I can pull up the official language. So the official impression was read as esophageal dilation with incomplete lower esophageal sphincter relaxation, resulting in stasis of barium and a barium tablet of the esophagus. Findings are suggestive of achalasia.
Anyone have any thoughts? I mean, that definitely like rules out tons of the buckets of the differential diagnosis that we had talked about before, right? So this definitely seems esophageal, right? And we see, you know, you have this description of possible achalasia. Definitely achalasia can be progressive, can be solids and liquids, can be associated with weight loss when severe. There's also like pseudoachalasia that can happen as well when you have like a malignancy and causing obstruction of the esophagus. So that's always something to consider. Does anyone know or think what happened next in terms of management?
So you have someone who
GI consult, yeah.
She has consulted. They did an esophagram. You have someone who's in a pretty severe heart failure exacerbation. His EF is now 10%. He's fairly volume overloaded on clinical exam and has a severe dysphagia to both solids and liquids and reports not being able to keep down any PO intake for at least 2 days. So the first thing that we wanted to do was make sure he was optimized from a cardiac perspective. So GI deferred any initial intervention until he was stabilized from a cardiovascular perspective, given his heart failure exacerbation. They didn't feel he'd be able to tolerate endoscopy at that time.
And Wanjun is mentioning dilation or stenting as well. So that's a possibility. I mean, that's an intervention depending on what you find, right? And like would kind of take you to the next step, like what Joe was talking about, the potential endoscopy and any other procedures that could be done once a little bit more stable in a patient with an EF of.
Yeah, I would say not only
I think we can,
but with a more clear diagnosis, right? Because so far the diagnosis is not yet clear. So before considering dilation, you really need to confirm what the diagnosis is.
Exactly.
So the next step, for diagnosis would be an endoscopy with biopsy to get a visualization of what was actually going on and a histopathology of the tissue to see if there was malignancy or esophageal or eosinophilic esophagitis or anything like that. So the next step for GI was to scope, but we needed to make sure that he was volume optimized first. So I'll go into a little bit of the hospital course. So he was in the acute decompensated heart failure exacerbation presentation, and he was seen by cardiology who recommended a pretty aggressive diuresis with IV Lasix 80 milligrams Q8. And he had the rest of his heart failure meds optimized. I'm not going to go too much into that because the case we're talking about here is dysphagia, but he has metoprolol, spironolactone, all those medications changed. The repeat TTE, as I'd said, had a 10% EF and worsened right ventricular function. And he was eventually scheduled for an endoscopy about 2 weeks after his initial presentation. After cardiology had optimized him, they deemed him euvolemic. He was brought down for the procedure on Monday morning, but his blood pressure was in the 90s over 60s, which is baseline and stable for him with his low EF. But anesthesia didn't feel comfortable proceeding with the procedure, given that his BP would drop more with the anesthesia, and they canceled it and he was brought back up to the floor. This begat the beginning of a very long back and forth between GI, cardiology, and the primary team with what the best way to sort of manage this patient's care was moving forward. The issue primarily being that he was unable to remain adherent to his medications as an outpatient, and GI's recommendation after being unable to tolerate the procedure was BID, high dose PPI therapy, for at least 1 month before reattempting dilation. And the idea behind this was that, oh, I think I skipped something in telling you about his history. Yeah, so GI had planned to do a 1-month PPI therapy, BID, before having him come back to attempt dilation. But on further chart review, we found that actually this would be his 3rd dilation this year. He'd been previously dilated in March and September under similar circumstances. He presented with a couple of days of dysphagia, had been dilated in the Mount Sinai system, and then discharged with full prescriptions, but had poor follow-up, didn't see GI as an outpatient. And so for this go around, GI felt that they wanted to make sure that he had robust PPI therapy for at least 1 full month prior to dilation, followed by dilation to decrease the chances that the stricture would recur. And there was a discussion with them. They said that, well, while there's active inflammation, the dilation does not typically go very well. And if a patient's not going to be able to return for serial dilations over the course of a month or 2 months, this would be the most optimal therapy. At this time, the leading feeling was that we should discharge the patient on BID PPI and have him return to the hospital or to GI outpatient in a month for follow-up. However, given his undocumented and undomiciled status and current inability to tolerate any PO intake, the primary team felt that that wouldn't be a safe discharge and advocated for keeping him in the hospital. Actually, he stayed in the hospital from December 20th to January 19th, just hanging out on BID PPI therapy. Despite his EF of 10%, he was very active on the unit. He'd walk up and down the hallway 3-4 times a day, which I think initially kind of freaked everybody out when we first started doing it. Then on the 19th, he was brought to the endoscopy suite. His blood pressure was about 100/70, so he just sort of got in the cutoff for what anesthesia felt comfortable with. And he went under a Savary mechanical dilation up to 14 millimeters and was planned for lifetime BID PPI therapy and asked to come back in 1 month for repeat EGD to repeat the dilation to ensure that it stayed that 14 millimeter diameter. During the endoscopy, it was noted to be a benign stricture. You can see here's a little bit of his lower esophageal stricture. Sorry. Sphincter. And you can see the salmon colored islets that are indicative of the Barrett's. Was eventually discharged on the 3rd to shelter with full prescriptions, but unfortunately never followed up with GI. About his hospital quarters or what happened with him.
Well, hopefully he didn't come back to the ED like this past month or whatever. So yeah, have you checked like if the patient came back or no?
Oh, I check his chart every now and then. I've been very curious about this guy. He has not been back in the hospital, thankfully, which I felt very happy about. Absolutely, yeah. Especially because during the time it felt like when I first picked up his care, it was the day that he had his procedure canceled. And it for days afterwards, he was very down and thought he wasn't unable to get the procedure. He was talking a lot about dying and how he just kind of wanted to die if he wouldn't be able to get anything done. And the primary team really wanted to get this dilation done for him because it was such a big quality of life factor for him. Given his severe cardiac status, that we just thought like he needed to have some way to have PO intake and feel good and enjoy the rest of his life, particularly since we were going to send him back to the shelter in the street and he was probably going to be unable to get good access to pureed foods, liquid foods, and be able to maintain the dietary restrictions he would need to with the severe stricture he had. So I don't want to keep anyone too late. We only have a couple minutes, so I'll go really quickly through my slides about dysphagia, stricture, and Barrett's esophagus. So I think, Rafa talked a little bit about it and we talked about it, sometimes patients will present acutely with dysphagia, and you want to be able to differentiate that, between an emergency where someone is having a a blockage of their airway or of their esophagus versus something you can manage sort of over time. So if someone has sort of an impacted food bolus and they're secreting copious amounts of saliva, there's some things you can do in the ED or in the urgent scenario to help try to pass the food bolus. You can give them IV glucagon, which helps promote lower esophageal sphincter relaxation. And then also, if you feel comfortable and the patient is, hemodynamically stable and there aren't other risk factors, you can do mechanical removal with endoscopically. They use a little net and they just sort of fish the food out. It's a very time-consuming process. Just a little bit about Barrett's esophagus. Barrett's esophagus is a metaplasia of the stratified squamous epithelium in your distal esophagus to the intestinal columnar epithelium that you would find in your gastrum. So normally in the stomach, you have this columnar epithelium that is more resistant to the acidic environment in the stomach. And you have a stratified squamous epithelium that's more similar to what you find in the upper esophagus. And it's not resistant to acid. So when you get GERD and chronic GERD and exposed to that environment, goes through metaplasia, change to the columnar epithelium to be more resistant. But obviously, as we know, metaplasia brings the risk of dysplasia. So it's most commonly caused by chronic GERD. Patients with chronic GERD have a 10 to 15% risk of developing Barrett's esophagus over their lifetime. Some other risk factors, which she had one of was smoking, obesity, and a positive family history. It's typically asymptomatic. Patients aren't going to find that they're symptomatic from their Barrett's esophagus or symptomatic from their GERD. So it's important to know under what circumstances you would screen a patient or surveil a patient for Barrett's esophagus. The kinds of things you might see Barrett's esophagus evolve into, which are really sort of more complications of adenocarcinoma and malignancy, or when stricture ulceration develop and they can cause dysphagia and odynophagia. But stricture is also a complication of GERD separately from Barrett's. So for the screening for Barrett's, you want to screen individuals who are having chronic GERD symptoms, heartburn, regurgitation, with 2 or more risk factors. So the risk factors that up to date and the ACG guidelines put out are hiatal hernia, age greater than 50, male sex, Caucasian ethnicity, central obesity, smoking, and a positive family history of Barrett's esophagus in a first-degree relative. And the current recommendation is to screen with upper endoscopy and biopsy. You can visualize Barrett's esophagus, as you could see a couple slides ago. I had his endoscopy down here. You can sort of see what a Barrett's esophagus visually looks like, kind of the salmon pink colored tongue looking appearance. The best surveillance is to take 8 random biopsies. They do it circumferentially. They'll take one north, west, east, south, and northwest, southwest, et cetera. So they try to get a clockwork, work their way up. And the current recommendation, this is a little bit something that's difficult in the field right now, is they recommend surveilling every 3 to 5 years for patients who have positive Barrett's to assess for the progression to dysplasia. Of course, you can screen faster if someone's got progression of their GERD symptoms, or you have some other reason to think that they're developing a malignancy. If someone has weight loss or things like that, you can increase the rate at which you're screening for their Barrett's. And then just a little bit about esophageal stricture, like our patient had. Normally, your esophagus is about 30 millimeters in diameter, and dysphagia occurs when the esophagus gets narrowed to less than 13 millimeters. And so typically you'll dilate patients to 14 or 15. Most commonly caused by GERD, but you can also see it in response to radiation therapy, other caustic ingestions, pill esophagitis, eosinophilic esophagitis, and malignancy. They're typically characterized as either simple, which is pretty straightforward, like our patient had. Simple, which is pretty straightforward, just a narrowing of the esophagus, typically still pretty wide, and you can pass the endoscope through them, versus complex, which is what our patient had. You kind of see in the esophagram, it was tortuous and long, difficult to pass the endoscope, and typically less than 10 millimeters in diameter. And then benign or malignant. And really that's just whether or not the stricture is caused by a benign process like GERD or radiation, or if it's due to a malignancy and a tumor. And then when strictures are deemed refractory, is if they've had greater than 5 failed dilations. And some of the treatments for that are glucocorticoid injections, which can reduce the inflammation and keep the dilation lasting longer. Or actually more recently, there's been approval for various stentings of the esophagus, including metal, biodegradable, and plastic stents. And actually our patient repeatedly requested having a stent placed, but GI didn't feel like he was a good candidate. think the last thing I want to say that I thought was pretty interesting was I wasn't aware that for esophageal dilations, particularly for benign strictures like our patient had, GI actually thinks you'll need repeated dilation before you'll have a lasting effect. And they typically like to dilate folks at least twice within a month to have a long lasting effect of the stricture. And they weren't surprised at all that this patient continuously needed to come back for repeated dilations and such. And so then this is my illness script. Barrett's esophagus and stricture are seen in patients with longstanding GERD symptoms and mostly in patients in their 50s, so middle-aged to elderly. Typically found on screening endoscopy, but can present with complications, most commonly dysphagia. And Barrett's is a consequence of, I didn't add the management. Barrett's is a consequence of repeated acid exposure to stratified squamous epithelium, causing metaplastic changes to resistant columnar and increased scar tissue formation. And the management, as we've mentioned, is PPI therapy and dilation with either mechanical or balloon dilation. Yeah. Questions,
Perfect.
thoughts, comments?
I would just go back to what we had discussed before, that the patient ended up not having malignancy, but in this case I don't think it's just cardiac cachexia, because here now we know that his dysphagia wasn't just acute for 2 days, but it was something recurrent, and so he must have been not eating well for quite some time. Plus his social, being homeless, there must be a social component to his weight loss. But it's interesting that there was no cancer; it was all other stuff.
It had turned out from further chart review, the last time that he had been in a rehab facility was April. So from April to September when he presented the second time, and then to December, it doesn't seem like he had any long-term care, access to food, access to his medications, or safe housing. So for quite a long period of time. And we sort of thought that weight loss that he had was, we were concerned for malignancy, but the Barrett's hadn't progressed to dysplasia on repeat, was that he just had really poor PO intake for months and months.
Yeah, it's especially challenging if they wanted to have 4 different dilations in a patient with a social history. That must have been pretty challenging.
I think that was the most challenging part, and I just think everyone on the primary team felt it was just so hard to want to discharge him, feeling that the chances that we'd get him back and he'd be able to maintain the treatment safely were just so low. We thought to keep him in the hospital.
Kind of along the same lines, I'm curious, did GI give a reason for why he wouldn't be a good candidate for a stent? Because not only for the social situations, but a guy who barely can tolerate being intubated for, risk of hypotension, seems like picking a procedure that has fewer actual procedures is a better choice.
I'm not entirely sure why they didn't feel comfortable stenting him. I'm not entirely sure. I think probably because they didn't feel he'd be able to necessarily maintain the PPI therapy you would need to for best stent recovery, but I didn't comment on it. But when asked, we were given a hard no.
Any other comments or questions?
Thanks, everyone. This was a really satisfying case for me. I actually got to be on his primary team when all this was going on and get the whole plan for his PPI set. And then I was on GI consults when he ended up getting his endoscopy. So I got to be in the endoscopy suite and see it. And that was kind of very fun. He recognized me, and that was really nice.
Continuity. Maybe you'll see him at Ryan.
Yeah, exactly. That would be great.
To me, it's funny that you say that, because to me, when I hear this case, what I feel is really frustration, right? Because, we live in a society that's a rich society, and yet the way it's organized allows for, for patients to basically die from lack of care and lack of support. because this patient, has conditions that, he could have done well had he received the proper care at the proper time. Only that, the social environment won't allow for that. And I can see the intentions of the hospitalists who said, let's not discharge him, let's keep him in the hospital, right? Which goes against what administration wants us to do, which is to discharge fast and stuff like that. So I see a lot of good intentions and people doing a lot for him. And yet, that the outcome is that he's going to go back to the streets, and, that there won't be a system to really, give him what he really needs. So that's why I'm saying, to me, it's frustrating,
Well, he has a GI appointment in April, so I will be checking to see if he comes to it.
Very good.
Okay, thanks so much, Joe Menand, for your very great, well put presentation. Very interesting case. So everyone can just go ahead and enjoy the rest of your evening. We're gonna record the report and upload it to our webpage. Have a good day.
Thanks, everyone.